Hello and welcome to The Big Debate. I'm Sigim Gabadeli. Now, we spend more per person than any other country in Africa on healthcare, and yet statistics show we are failing on health. Why does our health system remain in ICU, and what are the chances it will ever recover? Well, with me to discuss this are Aaron Motsoaledi, the Minister of Health, Blum Khan, the CEO of Metropolitan Health, the largest administrator of medical schemes in South Africa, covering almost 3 million people across 25 schemes. Ngaki Matlala is the Senior Executive of MediClinic, one of the largest private hospital groups in South Africa and the region. Vuyiseka Dubula is General Secretary of the Treatment Action Campaign, the country's leading civil society organization working to promote universal access to treatment. Richard Netononda is consultant cardiologist at Baragwanath Hospital. Letitia Rispel is head of the School of Public Health at WITS. In addition, we have doctors and nurses from the public and private sector, we have activists and academics, we have patients, and we have members of the public. Welcome to you all. Now, before we start to ask, does public health stand a chance? Let's watch this overview.
Dr. Langalani Mbodi has just started a 24-hour shift at the Charlotte Maxeke Johannesburg Academic Hospital. Rushing between casualty and his ward patients 3 floors up takes time and energy. At least he's able to run, unlike his patients in maternity. The lifts have been a problem for years.
This is where we have our gynae admission ward. As we can see, I can't even speak properly because even though I'm slim-bodied, I'm panting as well. Because this is the exercise we have to take because of the lift's failure.
Before he makes a dent in the waiting queue, Dr. Mbodi is called to theatre. Some patients will wait until tomorrow for his attention. Those are the lucky ones. The doctor shortage means a 5-month waiting list for operations.
It's currently affecting us a lot. For example, in anesthesia, we have a very long backlog of cases that we're booking for theatre. And the current ones that we booked, we find that we have to cancel them. And that has an effect. If you look at it on a person who needs an operation within a month period, if you do nothing within a month, then the patient might complicate, or the patient who has a precancerous lesion. If you don't operate that, it could have been cancerous.
Meanwhile, on the ground floor, the queues in the pharmacy are beginning to stretch out the door.
I come here from very early in the morning. Problem is there's a lot of patients.
The overstretched pharmacy staff can do little to speed things up. There's a critical shortage of medicines.
We have drug stockouts of antiretrovirals, which is catastrophic because patient, you sit and you tell the patient they must take the tablets, Oh, we forgot to order them. I think the drug stockouts issue thing is a really good example of just how the systems are starting to fail. I've never seen it as bad as it is at the moment.
But this isn't the only sick hospital. At Chris Hani Baragwanath Academic in Soweto, hardly a month passes without some emergency. When Dr. Mashudu Netononda returned from doing a PhD at Oxford in 2009, he was shocked to discover the decay in the system and lack of accountability among provincial bosses.
They buy things that doctors and nurses don't need. They're very good at doing that. And it's because of the tender system. There's a new style of buying disposable things, for example, disposable thermometers. I would have rather, with what we have, we improve things, and then go to South Africans and say, guys, you can see things are improving.
He now chairs the 700-member Doctors Forum at Bara that lodged a complaint with the Public Protector for redress. There have been some improvements in public health, widespread HIV treatment and better life expectancy, but big problems of leadership and culture remain. And then there's the impact of the private sector, which spends the same amount of money as the public system, around 120 billion, but serves less than 1 in 5 South Africans. In other words, private patients cost South Africa 6 times as much as those in public health. South Africa's private hospitals are recognized as some of the finest in the world. They say they give their patients the best, and they have much to offer the public sector. To keep beds occupied, they rely on highly paid specialists. But can the country afford this kind of high-tech preventative CT scanning for perfectly healthy people? Or is it over-servicing of a few people at the expense of the many? And what about medical schemes? By law, they were never meant for profit, yet their administration is done by companies that make profit for shareholders. To fix public health, should all attention be on the public sector? Or does the answer lie with the proposed National Health Insurance, or NHI, which aims to pull resources from the private sector to serve the whole population?
You know, I don't really believe that you can improve the setup by providing more money into the system. We first need to close the leaking taps.
Closing the loopholes, Minister, seems to be the key word, leaving us out of that insert. 4,300 women die in childbirth a year in this country. About 70,000 children do not make it to their 5th birthday. You failed.
The figures we are quoting is about maternal mortality and child mortality, which are particularly high in sub-Saharan Africa. And as you know, the biggest contributor of that is HIV and AIDS. Of course, the second is the issue of management of healthcare. And I was the first one to admit and said it openly that over the years, especially in the past decade, we have replaced a healthcare system with a tender care system. And let me correct Dr. Netonanda. NHI is not about putting more money. It's about redistributing what is there already. We are spending 8.5% of the gross domestic product on health already. The recommendation from the World Organization is that we'll have a better health care if we spend 5.
So we're spending 8.5.
We are already on 8.5. The problem is how it gets distributed. 5% goes to only 16% of the population.
We've heard all of this before, and that's, I think, the problem for all South Africans is we've heard all that diagnosis of the problem. We've heard solutions being thrown forward by the department, but we hardly see implementation. I don't want to wait until I'm dead before I see a solution.
The solution for distribution, we haven't seen it all yet. It is still in the planning stages.
How far in the planning stages?
It is called NHI. If you don't introduce NHI, which the World Organization said must be introduced in any country, there's no way you'll ever have equal distribution.
We're being told that NHI is not going to work if you don't fix the public health system first.
It's obvious. If you look at the plan for NHI, for the first 5 years, we are going to be doing exactly that. First of all, we need to massively improve the infrastructure. Secondly, the human resources. Thirdly, the quality of healthcare. Fourthly, is the re-engineering of primary healthcare. And lastly, to look at the cost of healthcare. Starting with using GPs, because we are one country that is using specialists more than GPs.
And I'm glad that you brought up the specialists, because I've got to bring in Gangi into this conversation. And I want to talk about NHI, because there is a school of thought that says we shouldn't be piloting, we should be implementing, but we'll talk about that. Gangi, let's talk a little bit about that. Matlala is the senior executive of MediClinic. You take many of the good nurses and the good doctors out of the public healthcare system, that you have resources that you are not using to their best example. The minister just mentioned specialists. People are getting tested for things that are not life-threatening, while we have poor people dying in public hospitals.
South Africa does not allow private hospitals to hire doctors. Doctors don't work for us. We provide the hospital, the nursing services, accommodation for the doctors, the wards, and theatre. This is a democratic country. Doctors work because they say, for many reasons. For example, some of them say it's the condition, some of them probably want to make money, some of them talk about salary, but they come to our hospitals. Okay. And there's nothing illegal about that.
Is that fair comment?
No,
is that fair comment?
Let me tell you what's happening, which is even worse. And I'm just about to cry. Sorry, let me not. You know, when I was a medical student, I had all the professors who I needed to train me. We've got professors who are now earning today 1.7 million. Today, under OST, but they come and work 1 hour and go to him and work there and get more money. How do I compete with them? I can't. There's no way I can.
The minister says he cannot compete.
Else can.
And here's the concern again. Here's the concern again, and I'm going to I'm going to quote the Freedom Charter. Free medical care and hospitalization shall be provided for all. And yet, you turn people away from your hospitals when you have beds available. How do you justify that?
We turn people away from our hospitals once they have been stabilized. That is the law of the country. The inputs that are used in our hospital have to be paid for. We, like all citizens, contribute taxes that also pay for all of the public health sector. Our hospitals open for people who can afford to come to our hospitals. It is true.
I'm going to bring in Blum Khan, the CEO of Metropolitan Health. The minister talks about competition. He talks about how he can't possibly compete with the resources that sit in the private sector. Your holding company last year, I think, made, almost 3 billion rand? And the contribution from Momentum Health, I think they increased their profits by 17%. And in fact, the holding company even paid shareholders dividends. Health is a basic human right, and not just dividends, a special dividend.
I want to expand access to healthcare to many more South Africans. We have to do it in a way that generates a surplus so we can reinvest that surplus. I can tell you that as a CEO of that business, I stand quite tough against my leadership to ensure that that money gets reinvested in healthcare. I can demonstrate to you that we are the lowest cost administrator in the country, and we went against the grain. The grain was something like, at a huge amount of money, people were doing administration.
Why should somebody profit from someone's discomfort?
If you look at the hospital sector, it takes a huge investment. You need to invest in that infrastructure. It is not capital that's easily mobile. And nobody's going to bank it unless you can demonstrate that it makes a return.
Right.
And so I don't think we should draw these linkages between sort of hardship and suffering to earnings. I think we need to separate that in the discussion, but keep an eye on where's the balance for returns.
Vuyiseka Dubula is General Secretary of the Treatment Action Campaign. And one of the things you say is, well, health should be free and that everyone should have access. But there's the little matter of the Constitution and choice. So if, for example, if I can afford to drive a really expensive drop-top sports car, why can't I go and do that? Just as if I want to go and give my money to him as a council, as an administrator, and go to his hospital, it's my democratic right.
Everyone has a right to choose where they need to access services, but majority do not have that choice. And I think that majority I'm talking about is the 86% of the population that depends on government.
But whose fault is that? It's not his fault. It's not his fault.
Well,
maybe it's the minister's fault.
The government has a constitutional obligation to deliver services. But where will they get the resources? Because they need to then regulate that within the health system, there's equal share of that responsibility. I'll make an example with HIV. None of the private healthcare has taken responsibility for the epidemic. We were dying. Many people were accessing healthcare and antiretrovirals in the private sector. They did not donate any drugs to the public sector. That is the fact.
How can people appear a lie? Yeah?
It's not a lie. So it's a lie. Why is it a lie?
It is a lie because I know that my company contributed more than 500,000 to drugs.
Where? In '98, there was 0 people on treatment in South Africa.
98,
in 2003, there were only government gave us treatment. Which hospital are you talking about? Let's be honest.
I'm talking about the Mediclinic company.
No. Don't talk Mediclinic. I'm talking about the clinic next to your clinic. Which clinic? Soweto, Baragona? No?
I think
give him a chance to finish the point that he's making.
Because
it's not.
No.
Please give him a chance.
We as private sector.
I'll give you a chance, Minister.
Can I question? Yes. I'm worried.
Yes.
Because here it looks like we are debating the similarities or the difference between public and private healthcare sector. And NHI is not about that.
No,
it's not a beauty contest between the two systems.
We are not conducting a beauty contest between NHI and the two systems. In fact, we're not even comparing what's happening in the public and the private sector. We're asking the question, does public health stand a chance? And if it's going to stand a chance, do these guys and the others like them need to change? Do you need to change? Whose fault is it? Does she have a point? That's what we do.
On that one, I agree with you. Both
that's my question. So absolutely, okay. I need to give you a chance to respond.
The private sector in this country treats about 15% of the population, it has been said. We also consider ourselves part of the citizenship of this country and will contribute like everybody in the improvement of the whole public sector. But we should not be expected to use our little business to take care of the whole country.
I don't think that's the expectation. I'm not sure that's the expectation, but I hear you.
No.
But I hear you.
We are not going to do that.
Yes.
Because NHI, and I want to ask a question.
Yes.
It simply says every citizen must have access to good quality, affordable health care.
Yes.
And that access must not be determined by the socio-economic status of that individual.
All right.
That is exactly how it is.
When I ask you to pause,
and that's NHI.
Yeah.
If we introduce it, will they agree? Why then there's a problem? Taxes will go high, we tax in the rich and all that. We are trying to put this access with a constitutional obligation on us. And the only way you can do it is that for those who have got resources, they must bring them
They must put them here.
And all of us change.
Will you agree? Okay.
We agree. We actually support the NHI.
Yeah.
And we also say that we do a lot of research in support of the NHI. All we are saying is that all of us need to come together to agree as to how this is done.
I'm going to ask everyone to pause. We're getting
it works in other countries where we are.
We're getting into some really good meat of the issues, and I'm going to hear a little bit later from Letitia on this one. Just after the break, we're going to hear from a doctor who's taking the Department of Health to the public protector. You're watching The Big Debate. And welcome back to The Big Debate. We're talking about health. Take a look at this harrowing story.
For many, the cost of health system failure has been high. Ted Tenehi's brother Godfrey was rushed to Chris Hani Baragwanath's overcrowded trauma ward after a shack fire. Godfrey could still walk and talk when he got to hospital. After quarrels about admitting him, he died.
They said there was no doctor on duty. I asked for a doctor's schedule. I was not given to. I asked too many questions. I should leave. I asked then who was their seniors. Nobody could give me any information to their seniors. The most disturbing thing was that the nurses showed no compassion.
Well, Ted is with us here in our audience. Ted, what would you like to say to our panel today?
Do we have a healthcare system that is operating, or we have a healthcare system that is bet on it, meaning that should you put money before your life?
We're sorry for your loss.
Thank you.
I'm sorry for your loss. Minister, I know you can't comment on the details of a specific case, but this is someone who died in a public hospital. What do you say to Ted and his family?
Well, any human being who dies in our hospital is a very painful thing. He said he went to Chris Hani Baragwanath Hospital and they said there's no doctor on duty. That hospital has got more than 800 doctors. It is more than the total number of doctors in the Mpumalanga province. Our own audit has shown it. This issue of non-caring attitude of staff, you realize that we put it as one of the core standards to be inspected by the Office of Standard Compliance. We picked it up.
Richard Netononda is a consultant cardiologist at Baragwanath Hospital. You were taking your employer to the public protector.
The problem is that the leadership in this country doesn't actually care about the citizens. You know, they're just interested in themselves and their families. And the public of this country is taken for a ride by government, by the private clinic, the private sectors, and by the medical aid schemes. And by the way, Ziki, the medical aid scheme will only look after you as long as you're working. Come the day when you retire, as soon as you retire, they dump you.
Then you have a problem. There's a number of sweeping generalizations, but in a case where the minister says to us that Baragwanath has more doctors than a hospital in Mpumalanga, and in the whole of province of Mpumalanga. Yes. And his brother goes in there and dies because he's told there is no doctor. What actually do you think happens in that situation? I understand, I think you're taking it towards a leadership crisis issue.
The public health care system in this country is dysfunctional, Ziki. We say, has it got hope? I say it's collapsed.
You know, it doesn't function. And that dysfunctionality is manifested in hospitals, in clinics. You saw Dr. Mbodi in the inset.
Yeah.
The doctor who had to use a cell phone to finish off a delivery because the power went off. And it's not because, even if you look at the public sector alone, we have got enough money. But we've got wrong priorities because they are vested interest by powerful individuals.
Well, Minister, I need you to respond. We've raised the issue of entrepreneurship. You've said it yourself, but nothing's done. So do we need to change leadership?
We have started last year and we have agreed with the MECs. We are putting up a system which you call non-negotiables. I've put all the things that no healthcare system can run without and call them non-negotiables. If they buy something else that is not necessary, you'll question them and say, no, but we don't have this, that's non-negotiable. We put pharmaceuticals, we put equipment, we put vaccines, we put food.
But make sure that there's management in place that can manage them, because the problem
issue
right
of
now
management,
is that
issue of management, fortunately, that's where, despite all the arguments we have had, that's where we came together. We launched the Leadership Academy for Leadership in Health and Management. Together with Harvard, with experts from Italy, we've been training CEOs. And by the way, we're appointing new CEOs. Yeah. Will never be allowed in any hospital until they go training through that management. Where the private sector came in, I said they must contribute the money.
Letitia Rispel is head of the School of Public Health at Wits. Letitia, I'm seeing finger pointing, I'm seeing yes, but, no, but. Are we in trouble?
The very sad case at Chris Hani Baragwanath Hospital is also around how do we make sure that citizens are empowered to actually demand the rights that are in the Constitution. In this case, Ted asked for who's the manager. You know, that kind of thing, there should be a prominent display of the Patients' Rights Charter. He should be able to have some recourse, you know, to complain, and he should get a report back. We must make sure that there's individual accountability, both on the part of the individual healthcare professional, be it a doctor or a nurse.
Not only political leaders, as the doctor is saying here, because he's running away from his responsibility by ravishing us. You know?
Yes,
he is also a leader.
Let's allow Letitia to finish. You know, I've been very quiet, so let me finish. And as well as the manager and minister, I think one of the problems we have is that in the public sector at the moment, there are no incentives. If you're a good manager that do really well, that manage your budget, you know, that your staff love, there's no difference, or you're not corrupt. There's no incentive and no difference than the one who just coaches along, doesn't actually meet any targets, overspends the budget. So I think we need to look at accountability, and we need to make sure that there's actually consequences.
Phakama, as the September National Imbizo, you were saying public officials need to use the public health system. They must be forced to do so. Why?
Basically, our campaign, which is the People's Manifesto, says that our minister there, and together with his public servants, must use public hospitals, because someone talked here about priorities and people not having the right priorities, and that's because they know that they can take state money, by the way, and run away to private hospitals for themselves, for their families. Let's see how the minister, when his wife actually goes into a Baragwanath to try and give birth and might be one of those 4,300 women that don't actually make it. Let's see how he talks about we have plans. Let's see how he talks about training CEOs for another 5 years or so is such a big deal. Let him then tell us, with the men in the private sector there, that it's not important to actually deal with it as something urgent. I mean, we're hearing a lot of postponements and national health insurance, but at the same time, our government, together with the private sector, are on the same side.
I'm doing that, Sisi, and I support you 100%.
No?
Go and check my record at Steve Biko Academic Hospital. My wife has been there. My 2 kids have been there. Last week I've been there. Go and check.
Which is great, Minister, which is great. But what you haven't gotten from my proposition is that it must be made law that you go there. Because for you to do it, because you want to seem good, you want to look good, a majority of black South Africans in this country... No, Minister. A majority of black South Africans do not have the choice where they take their kids and their wives and themselves. So for you to stand here managing a system that kills blacks systematically. We can't say it's the nurses' fault because they're not caring. You're not paying them enough.
Okay.
You're overworking them. There's
Minister,
a whole
Minister, let's give the Minister a chance to respond. Minister?
She is making sweeping statements now. In the 10-point program, we said we must provide strategic leadership. And we emphasize that leadership is at all levels. You don't look at one person, the minister. Wherever you are, whether you are a minister, an MEC, an HOD, a clinic manager, a CEO, a clerk, you must take leadership at that level where you are. And that's what we are trying to do. Whether you turn that into a law, that everybody must use public facilities, is not for me to tell. The country will choose. All I'm saying is, I agree with you, because for the same reason that I don't hate private health care, but at all material times, it will always be for a selected few. Okay. It can't be for a majority of people. Right. So the public hospitals have to work.
I don't agree to making it law that they should, because you're treating the symptoms and not the problem. The problem that you should make law is that Parliament can't have two funding mechanisms. Parliament must have one funding mechanism. Scrap the Medical Schemes Act. The National Health Insurance should supersede the Medical Schemes Act. All the assets under medical schemes must be put under his authority. Then you've got a solution. Then they can choose to go private, not assisted by Parliament.
But not assisted. Mr. Bloom, what do you think?
I think we have to follow the Constitution on this, and that wouldn't be constitutional. But I admire the Minister for using public hospitals. The problem is I don't think he's treated as an ordinary patient is treated in a public hospital. So it's very good. I'm sure you skip the queue. I mean, it just happens. You're the Minister.
Do you skip the queue? A statement was made by Dr. Motsoaledi saying that scrap the medical aids, make the NHI supersede what you do. What's your response to that?
The industry is already consolidating. In 2000, we had 144 medical aid schemes in the country. We're down to less than 100. But the sense that I get is that if you have larger risk pools to manage and the funds are in larger pools, you get more efficiency out of it. It creates quite an interesting procurement opportunity. And those dynamics we're starting to see play out in large schemes like GEMS and some of the other large competitors in the market. And NHI as a funding mechanism, I think, has got legs, and we should look at it closely, because it will create a very interesting opportunity for an agency to start procuring services not only from the public healthcare sector, but from the private healthcare.
Put you out of business, though. What would you do?
You know,
one thing
about business, it is able to adapt to its environment it finds itself in. If you can centralize the funding, and I want to bring this into the debate, is where is the difference between the national government and the provincial governments and the local governments, and is there some almost dysfunctional components in there that if that's better aligned, the coordination of healthcare starts to come through much better.
Let me hear what Letitia has to say about that, and very, very quickly, Letitia, is there a problem between those three layers?
We almost have 10 different health departments in the country. There's a disjuncture between national government, which largely oversees policy, but national also has a limited role in the resource allocation for health. The only tool that they have are some conditional grants, but to a large extent it depends on the power of the health department in a province as to how much money they can get from Treasury, and that's a huge problem. It creates huge inequities across the country. Many of the provincial health departments are not functioning or very poorly functioning, and that creates another set of inequities that have to be addressed.
10 national departments of health in one country of 51 million. When we return, we ask, is the private sector part of the problem, or is it part of the solution? You're watching The Big Debate. And welcome back to The Big Debate on Health. Now, the private health system spends 6 times as much per patient than the public system. Does this imbalance make it impossible to fix public health? And there's a question for you, Minister, before we hear from our audience here. Regulation. I've heard lots of people saying you should be regulating the private sector more and more. What's your view on that?
That story that healthcare can just be left to the market, we must bury it here and here now. Because healthcare is not any other commodity. It's about life. It's not any other commodity which you can just exchange on the stock exchanges of this world. In South Africa, the biggest problem is that we are regulating only one side. The regulations are to regulate medical aid schemes. That man there is regulating them. And he's making this one, the CEO of medical aid, complain. He's regulating them. But who's regulating the providers?
Yeah.
Every time we tell them something, they go to court and they hit us. So we are trying to put regulation. The providers must be regulated.
Okay.
They can't just charge anything they want. In the NHI, it will be there because we'll set the prices and say, if a Caesar is 10,000 rand.
It's 10,000 rand
yes.
everywhere.
At the moment, nobody knows what a Caesar is. It can be anything. It doesn't, nobody knows how much it costs.
I've even heard of prices above 25,000 rand.
Yes.
You are with the Board of Healthcare Funders, Dr. Zugwifo. I mean, we're talking here about regulation. It seems there's different levels and different trains for different people.
It concerns us that on one side of the equation, the ordinary member pays the medical aid a contribution which is higher than CPI. And that has been the situation for the last 10 years. On the other side of the equation, the medical schemes at the same time hit deficits running into millions and billions of rand. In between, providers are being paid huge sums of money. Close to 60% of that, or just above 60%, goes to private hospitals and specialists. 36% to private hospitals, 27% goes to specialists. Now, that's the unregulated part. The third component of that is medicines, about 17%. That's the regulated part. The concern we have is, if we want to reduce the healthcare costs so that we don't load the members with high contributions like that, we have to then look at those two cost drivers, the private hospitals and specialists. The medical scheme industry doesn't have power at all to regulate that, doesn't have power at all to impose anything on those. In fact, the power was taken away by the Competition Commission.
But why are we paying you so much in the middle? Why are we being charged so much in the middle? Why do you have that slice of the cake?
Because that middle is not regulated. We're chasing that price.
So you'd be happy to regulate?
Very much so. Okay. We're supporting the minister all the way, 110%. Right. I wish that regulation comes in tomorrow.
Okay, there we go, Minister. Let's write this down very quickly. I just want to check one thing with Dr. Litapo. One thing?
It is erroneous to say the practitioners are not regulated. They are regulated, and there are prices. And as you say, the Competitions Commission interfered. But there was interference predating that. Because prior, under the Medical Schemes Act, there was guaranteed payment and there was a certainty about what the costs were. So it became a commodity. Payment to providers was no longer guaranteed, so the ability to negotiate decent rates with them disappeared. And it became a stock market approach. So I think we should not be selective with the truth. And it would be erroneous to bundle providers that are professionals with the institutions that are stock listed. And secondly, even amongst the providers, there was selective destruction of the gatekeepers. You want to go back to the primary healthcare model. The medical aid scheme destroyed the GP, which was the gatekeeper. So you have a hospice-centric, technology-based, highly expensive model of care, and even the benefit designs of medical aid promote that. You practice cost effectively, they don't pay you. You buy a machine and you do everybody, they pay you. So the designs, people are told, you want to go and see a GP, it's out of pocket. You want to go into hospital, we'll pay for it. This is a sick system that requires the minister to give it the last injection.
Can I have my microphone back? Gangi, you are under attack and I need to give you a chance to respond.
No, I'm not under attack. The private hospital sector has never said it does not want regulation. That's number one. We want regulation so much that we wanted protection from the law when we were abused of regulation. We went to court.
What do you mean? Just give us a little bit of...
There you go. There was a process that was to establish a pricing process in this country, which we were part of. We consulted experts, internal and external, who came with recommendations to the Department of Health. Then the Department of Health looked at that and said, we don't like that. Then they started imposing some form of regulation that the honorable judge found was flawed. So we've been waiting in a vacuum. When we were approached about 2 years ago to say that here is a recommendation from the department, we said, but how can we do that when the Competitions Commission has told us it is illegal for you to sit down talking about pricing. We are rekindling those discussions. We are saying we need to find a solution. All we are saying in the private sector is that pricing, whatever pricing that we come to, has to be informed by evidence. That is, it has to be scientific. This ship is big. It will take time to turn. Unfortunately, during that period, a lot of people are still going to suffer.
And welcome back to the big debate. Having heard the inputs from our panel, from also our other contributors today, does public health stand a chance?
When are we going to say, let's focus on the positives and build up from the positives to where we should be with national health insurance or private healthcare system together, working together? It's getting tedious, it's getting boring. Why don't we have the Minister of Finance here talking about how it's going to be funded?
It's all very well to be talking about integration of private and public, which I agree with, but in many places in South Africa, individuals don't have access to the private sector. We know as a fact that there are, in many areas of our country, those that are the most populated, the least economically resourced, and have the highest burden of disease, receive the least allocation with respect to the health resources in our country. The Minister rightly says primary health care is where it's at, but we need to be getting out there and we need to be resourcing our rural health systems.
I hear that most of the time it's about doctors and medical aids and whatnot, and yet in this country, if you do not have nurses that are properly trained, you will not be able to achieve what you want to achieve. And I want to appeal to our friend in private sector, that specialist nurses that are trained by public sector, they actually, after they finish their year, they go to private sector. And to you, Minister, you mentioned non-negotiables. And non-negotiables are still going to be bought. We still have to sit down and actually see where are we going to buy the non-negotiables. And that is where the problem is. Because here in this country, somebody mentioned that if a child grows and the first word that is going to say is mama, the second one is going to be papa, and the third one is going to be tender. So we're in big trouble.
To the private hospitals. You know, one thing that the minister has raised adequately, if government takes a decision, you run to courts. How are you going to ensure that we work together with government without making sure that when government take decisions, you just run to the court and defend what government wants to do?
I think in the debate around national health insurance, we don't put enough emphasis on why we need a national health insurance fund. And it is absolutely critical if we're going to achieve change, because it is establishing that body as a purchasing organization, an organization that is going to look at what are the healthcare needs of the population, where are the healthcare needs, and actually direct resources to where the need is. Private really is going to have to come to the party, because as was said, every time there's pressure on prices, the private sector runs to the courts.
I'm very interested in this idea of public servants, of politicians using the public services that they do provide. Because I think the way that we're having this debate is the way that most South Africans are evaded by the issue of health. We're talking about medical aids. We're talking about two streams that feed into Parliament. I think if the minister's children have to go to Baragwana Hospital, if his wife has to have a child there, if they have to go to a school where NG Motsoaledi could possibly be sending textbooks, I think if they have to live in a house that could possibly be built by Tokyo Sexwale, they're going to fix those issues. They're going to know what the problems are and where the problems are. We vote them into power. They get to walk out of these problems and go to private services and then kind of do whatever they can do to help us and not actually do what must be done, because it no longer affects them.
I think that the topic for this debate was quite interesting. You know, does the public sector stand a chance? And I think it's a bit of a fallacy. The question itself is we don't have an option. We should be progressing to a stage where all healthcare is provided by governments in a public system. That's not to say that there's no room for the private sector, but a very closely regulated private sector that can actually provide quality services to everybody is what we need.
I've got a nice story for you to tell. In the rural area of Lanseria, out of nothing, the community came together, built a clinic. We worked there as well. As the staff, we decided to change our attitudes. Our cleaners are tapping on the computers. It's a wonderful thing to see. All these problems that people are having, it shows that with almost no money spent extra, we can do so much more. It is just the attitude and the willingness to change.
Unfortunately, time runs out, so what I do have to do now is give my panelists a chance to firstly respond, but as you wrap up with your final closing thoughts, does public health stand a chance? The fact that we have to ask that question is quite tragic, so I'll start with you, Bloem.
Let's focus on pooling the resources, and the National Health Insurance Fund seems to me an amazing opportunity to leverage the kind of capability it can have in terms of procurement, in terms of aligning provision and services to, I think, a much broader area of our community. And I think we should focus on where are the quick wins and what do we do to drive it and get on with it, I think.
Get on and pick up the momentum for a second.
The health system needs to reform to ensure that every poor South African has an equal chance, just like if you are rich or not rich, you have an equal chance to live longer. At the moment, we don't have an equal chance. And I think financing is one of it. As many people have mentioned, we need to reform the whole system in terms of accountability. At the moment, we find that the minister is the one who has to explain to everyone why there's no medicines at the hospital, but the MEC in provinces don't take any responsibility. Instead, they chow the money in provinces. So we need accountability in the health system, and that reform has to cut down to communities and what is my responsibility towards my health and ensuring that government is taking me seriously. And I think some of the suggestions that are being made are being taken have to be taken serious because it's coming from a point of frustration where many people are being taken for a ride. When they go to the health system, there's no one who wants to take accountability. If you want politicians, if you're asking them, then they ask to go back to your minister who told you that there are drugs today. And it's a public official who's telling me, a citizen, that I must go back to my minister because they don't take citizens seriously. And I think the reform will force them to take citizens very seriously, and unfortunately as citizens we have to organize. Otherwise, if we don't organize, we're going to be taken for a ride by people whom we elect and put them in power.
It's not rocket science, you know. Any layman can walk in any hospital or clinic and they will really tell you, exactly where the problems are. I think what lacks though is the will at a leadership level to seriously address those problems and actually be honest. The federal system of provinces with many MECs and many levels of management, very bad management for that matter. In fact, that system is not working. But provinces have got so much vested interest in continuation of the system. If for once as South African, we can look at ourselves as one, as a nation, in terms of now and the future for our children, and begin to pull all these various components together. Let's solve these things. We know what the problems are. Let's deal with them. But for us to do that, we need to forget about our individual interest. We need to put that behind and put the interest of our nation, ahead of our personal interest.
Honest about
and be honest.
The problems
and be honest.
Siki, my concluding comment is that South Africa is one of the most unequal societies in the world, if not the most. There's recent evidence that shows that inequalities, the kind of inequalities between the private and the public sector and between urban and rural areas, it's bad for society's well-being. And so it's in our interest to actually get the public sector to work really, really well. We need to focus on leadership and governance and accountability at every level of the health system. And lastly, we need to make sure that the good policies that we make, and it's true, South Africa has probably among the best in the world, there's a huge gap between policy and implementation. And so we must get implementation right.
All right, I'll give you a final word, Minister. Let's hear from Ganki.
Thank you very much, Ziki. We must be thankful, and I'm not placating the minister. I have said earlier that I've lived through several ministers post-independence, and this is the first minister who really has passion about changing this ship. He's concerned about the society as it is. And as such, we should work tirelessly towards supporting him, but we must support him with evidence. Somebody earlier said we should stop, as private sector, taking government to court. Minister, many times it is not your fault that we do that. These are laws that are made by our own government that we respect, and as citizens we will be protected. If the judges are making unlawful decisions by finding the Department of Health guilty, then there's something wrong. But most of the time when we go to court, we tend to win because the people below you misbehave and tend to impose unlawful issues on us. And that's why we go to court, and we will continue to go to court if we are wronged. We'll continue to do that. Yes. But we have said as a private sector, we are willing to bring our shoulder to the wheel to turn this ship around.
To turn the ship around. Final word, Minister.
Yes, I was saying we need to work together. And I just want to remind my friend here, in 2009, I called all the stakeholders, medical aid, private hospitals, specialists, GPs, organizations like SAMA. I said, let's start putting a system to work together and stop running the healthcare system from the courts of law, running to court all the time. I really appealed for that. Because why did they take me to court? I wanted affordable healthcare. I'm not apologizing about that. I want healthcare to be affordable. And so when the Competition Commission said I must set prices, I'll set them low because I want everybody to afford. Then they run to court. And that's exactly one of the issues that we need to resolve. Because I can't be a minister of health and want higher prices for the citizens. I want them to afford. So I'll say, if they say charge the price for a Caesar, I'll say 5,000 rand. I won't say 30,000 rand or 100,000. Then it's a court case. What do I do? I can't run away from that.
Unless South Africa turns its public health system around, we're not going to be able to address all of our problems, from unemployment to social equality. And to sort out public health, we're going to require a change in attitudes, and that's throughout the whole of South African society. So, does public health stand a chance? You decide. Thank you for watching The Big Debate.